Good morning. Welcome to MED120 40AX. It is Monday morning, week 7, is it? Wow. November 22. And what is due today? Of course, all week 6 items, quiz, discussion forum, which is, we're not doing discussions anymore for this particular class. We're doing make your own quiz. What else? So this is all the stuff we're going to be doing today. Chapter 10, Musculo-Skeletal System. And this is one of those chapters where, you know, this will benefit you in your future anatomy and physiology classes if you haven't taken them yet, and definitely in your pathology class. Because, and also for if ever you guys go to graduate school and take gross anatomy, musculoskeletal system is one of the most, I don't know, it's daunting because there's so many things, there's so many terms. And if you use your medical terminology powers, it'll make your life much, much easier. I remember in undergraduate, all I did was try to memorize it. But remember, medical terminology is not English. It's Latin with a little bit of touch of Greek. So it's another language. And trying to memorize everything is not fun. It's better to recognize the name and then identify it that way. So chapter 10, let's jump right to it. And the people who are in our neighborhood is the first set of people is orthopedics and rheumatology. Now, orthopedics, they are a subspecialty of surgery. Ortho meaning straight, peds meaning to walk. Or so they do manage medically, but majority of their management is surgical in nature. So a lot of the things they're going to correct is like if you got broken bones, or you got damage to your joint, or you got a tear in your ligaments and tendons. And the people who manage things medically are the rheumatology people. And that's a subspecialty of the Department of Medicine. So you went through 4 or 5 years. Who am I kidding? 5 years. Why do I think internal med is only 4 years? No, it's 5. Some places it's 6. 6 years after medical school. Then you take your boards. And rheumatology, rheumat, is kind of, the best way to put it is, it means like you're dealing with the fluid in the joint space. Because if those of you who took anatomy and physiology, you recall a diarthrotic joint, also known as a synovial joint. Synovial joints are fully movable joints, fully voluntary, and a joint is a space in between two bones. And the rheumatologist is the best person to manage the common arthritis, or you'll hear the term arthritides. So osteoarthritis, rheumatoid, I've got RA, that's not fun. And rheumatology, think medical management. Orthopedics, think surgical. Now, chiropractic medicine, I used to have beef with these guys because a lot of them love to be called doctor, and they have an undergraduate degree, which used to bother me. But now I really wouldn't care less. You know, call me Susan all you want as long as the bills get paid. But chiropractic medicine, they're not like a medical doctor. They don't do drugs, they don't do surgery, but the thing that they do is they do manual manipulations of your spine and of your joint spaces, which is actually very beneficial for a lot of patients, especially those, you know, and there's a subset of patients where it's their joint problems aren't bad enough to warrant these guys, but they're bad enough to have a chiropractor look at you. And a very, very good friend of mine, everyone calls him Dr. John. I don't understand why no one calls me Dr. Nelson, but they call him Dr. John. Well, he's a wonderful chiropractor, and I have some joint stuff, and he's done wonderful stuff for my spine and for my knee. And also, They're also very good at a massage, and they can order X-rays and CTs, but it is still the radiology, or the radiographer is, well, the radiographer is the person who takes the snapshots, takes the X-rays, but it is the radiologist, the MD, who still gets to read it. So my good friend Dr. John, he can order, like if he sees something weird or odd with your movement or with your spine, he can order your X-ray and or CT, but still at the reading will be performed by an MD, most likely the Department of Radiology. And radiology works very close with orthopedics and rheumatology, because we need to see X-rays and need to see, how the joint spaces are. Now, this is a typical example right here. Make it a little bit bigger, of how, if you know your medical terminology, it'll make your life so much easier when you study anatomy and physiology. So one kind of way that you can look at muscles and things like that is by shape. So if you look at this deltoid, delta is the Greek letter for a triangle, and this is your deltoid. Oid, suffix meaning resembling what? A little triangle. So you can see this. And then you have your rhomboid, right? Which is, well, it's kind of underneath here, and it looks like a rhombus. And you have a trapezoid, which is like it's like a squished rectangle. So you have one side here, another side here, another side here, another side here, and that's your traps, or your trapezius, because it's in the shape of a trapezoid. So delta, and then you have underneath here, that's your rhombus and your trapezius. So that's by shape. You could also do it by number. You could see here, triceps brachii. Tri means 3. You can't really see the 3 heads here, but there's one like behind here. So your triceps brachii has 3 seps, or 3 heads. Cephalic means pertaining to your head, just like a like a triceratops that has like 3 horns. Tricycle has 3 wheels. You also have here, right here, it's your biceps. So there's one here, there's another here. You have a lateral head and a medial head. So that's biceps. Triceps, posterior, biceps, anterior portion of your upper arm. You could also look at things by size. So your pectoralis major is the major or biggest muscle in your chest. You have a minor and you have a medialis as well. And it's all underneath here. And you could see dudes and dudettes who have like 2 or 3% body fat. You'll start seeing separation of the pectoralis major muscle up here. You have your gluteus maximus. So the main muscle here in your buttocks is your gluteus maximus. Okay, has a lot to do with you lifting things and walking. You have 2 smaller muscles, the medius and minimus, that are underneath. Oh, here's another biceps. Okay. Now, regarding shape again, rectus means, when something's erect, that means to stand up straight. So a rectus muscle is straight. So your rectus abdominis has to be the straight muscles here in your abdomen. You have here obliques. They're going obliquely or diagonally. That goes here. Okay, you have external and internal. Oh, regarding shape as well. Look at these. Don't these look like a serrated edge of a bread knife? Hence the term, I used to call them riblets when I was a kid. This, again, with people with like 2% body fat, you will see these serratus muscles, and you will see the striations of your oblique muscles here. What else? Oh, location. Oh, here, more shape. Your orbicularis oculi. An orb is something, you look at this O, it's round. So your orbicularis oculi has to be the round muscle surrounding the oculus, which is your eye. You also have an orbicularis oris. So that's the circular muscle around your mouth. Muscles can also be named after what they do. So this right here on your cheek, if you put your hand to your cheek right now and pretend to chew, you'll feel this little muscle bumping in and out, and that is your masseter. It helps you masticate or chew. Also location as well. For example, your biceps brachii, your brachium or your brachial artery is, of course, in your upper arm. So your brachium is your upper arm. So your triceps brachii has to be the muscles around your upper arm. Biceps brachii has to be the muscles around your upper arm. Your brachioradialis has to be a muscle that connects your brachium or your upper arm, which is right here, to your radial bone, which is the bone closest to your thumb. So you can see how it comes here from the upper arm and then goes down this way. You have your biceps femoris, your femoral, which is the largest long bone in your body. That's right here, the femur. Okay, biceps femoris. So let's start looking at some words. Now, all of these muscles are covered by an extra set of fibrous skin. And you guys probably already know that, like anytime you eat chicken, ever eat a drumstick after you take off the juicy, crispy skin? There's a skin underneath the skin, and that's called fascia. And that's an extra covering for your muscles. And if that rips, you're gonna have a hard time walking around or moving around. So the orthopedist could perform a fascioplasty. Plasty, process of surgical repair of what? A fascia. There could be other fibrous tissue there holding things in, holding muscles in its place, and you could get a tumor there. That's called a fibroma. And anything that's fibrous or has lots of fiber is tough. So the fascia and the fibrous tissue, like the tendons over here, tendons connect muscles to bone. So I could also do fascioplasty and a tendoplasty, probably secondary to really bad tendonitis or a tendon tear. If I have a tear, I have to cut away certain parts of it so it can heal, and that's a tenotomy. And again, Department of Orthopedics gets to do all that. Now you have striated muscle and smooth muscle. Striated muscle is striped if you look at it in a microscope. And those are the muscles that you can move. Those are your voluntary muscles. But your visceral muscles, or the muscles in your viscera, your gut, your smooth muscle, you can't control. For example, can you control when your stomach makes odd and weird noises and start grumbling in the middle of a lecture? No, can't. And that's a visceral muscle. And you could have a tumor there as well. And that's a leiomyoma. Loins, that's your waist or lower back. So your lumbar is in that area. So lumbar support. Right now I'm in a chair with like one of those little pillows that support my lower back, and that has lumbar support. Muscular, pertaining to your muscle. Myorexis, rupture of a muscle. Remember, working out is good. Working out too much is bad, and you could get myorexis. You can also get myorexis due to some sort of muscle pathology as well, like tumors and really severe myositis. We already went over tendon. Algia is pain. So if you're having muscle pain, myalgia, and for those of you who work out regularly, it's okay to get a little bit of pain or tenderness. But if you're working out to the point where you can't walk up and down the stairs, that's a problem. The other day I went a little nuts on leg day, pretending I was 20 years old again. I couldn't move up and down the stairs. It was it felt like my thighs were on fire, and that's myalgia, pain or tenderness in the muscles. Myasthenia, weakness or debility in your muscles. Myasthenia gravis is a neuromuscular junction disease where you get progressively weak during the day. So, for example, I had a classmate of mine, Dr. JD. I remember we were in third year, and he said he wasn't feeling well. So he said he felt like weak and like sleepy, and I'm like, oh, that's normal. We're in medical school. Well, he tried to hail a cab, and he couldn't raise his arms, and that was around 10 a.m. Then he collapsed in front of the hospital, was brought into the emergency room, and I had ER duty that day. And I'm like, JD, what's up? By 11:30, he was having a hard time even talking. By noon, we had to hook him up to mechanical ventilation because he couldn't. He stopped talking and he couldn't breathe, all because of the neuromuscular junction, where the nerve and the muscle meet. And myasthenia gravis is a very, very serious thing. My good friend JD was on a mechanical ventilator for the next 6 days. And you know what's funny? When the school marked him absent, they marked him out of post, even though he's in the hospital. You believe that? They almost made him repeat a year for 6 days. That's messed up. But hey, welcome to medical school, I guess. Myopathy. Myo, of course, muscle, pathy, disease. Plegia is paralysis. Let's look at the different types of paralysis. Let's find a nice picture. It's not a pretty. Okay, well, as best as we can. So if you have monoplasia, plasia is paralysis. You only have like one limb. Hemiplegia, you think half, either the right or the left. Diplasia or diplegia is two limbs, typically both arms, right? But when it's both legs, it's paraplegia, means paralysis, or I can't move from the waist on down. And quadriplegia usually means a cervical spine problem. It's from the neck on down. So quadriplegia, quad means four. So it's 1, 2, 3, 4, all four. Paraplegia is, of course, from the waist on down. Hemiplegia is either left or right. Now, when you look at the word paralysis, paralysis. Paralysis means, let's see, nice pretty picture. Okay, cervical region pertaining to your neck, thoracic region pertaining to your chest, lumbar region pertaining to your loin or waist, and your sacral is all the way down here, right? So you have your spinal cord here, and then you could see these spinal nerves exiting the spinal cord. Now, the term paralysis comes from this concept. Para means alongside. Lysis means breakdown. Let's say I took a knife or a hot poker or something awful, right? Or table saw. I don't know, pick your choice, right? And I cut you along the side. That means I would ruin all of these spinal nerves. And if I ruin all those spinal nerves, guess what you're going to have? You're going to have paralysis or breakdown of along the sides. And that's what do you call it? And that's what paralysis actually means. Rafi, suturing. So if I did a tenotomy, I also, and I have a tear in my tendon, odds are I'll also have a tear in my muscle as well. So I'll have to do a myopathy, or the orthopedist has to do a myopathy, which is the process of suturing a muscle. Myosarcoma, they are especially nasty, and they love connective tissues like tendons and fascia. Sarcoma is a highly malignant tumor. So you see sarcoma, you think what? That's cancer, that's a carcinoma, and it's highly malignant, and it's a tissue tumor. And in this case, connective tissue tumor. Okay, let's see some other words. Myogenesis. Genesis means the formation of. Myo is muscle. Surgical repair, suture, we already went over that. Myodynia is another way of saying myalgia. So myodynia, dynia is pain. Myalgia, doesn't that look like a beautiful both A and B question? Hint. Sclero, of course. Sclerosis of a muscle means it starts hardening. And that's myosclerosis is an abnormal condition of hardening of your muscle. 3 heads, 2 heads, remember triceps, biceps. You also have 4 heads, your quadriceps or your quads, and that's in your thigh or your 4 femoral muscles. Tendon, Achilles tendon. Oh, let's look at this. These are your movements. This is not as important for us, but crazy important in any of your future med surg classes and your pathology classes, because you got to know how people move and how to document movement. One way is to talk about the movement itself. And another way is also to talk about the angle here. So if I'm doing flexion, like this model right here is doing, she is decreasing the angle of her elbow right here. Hence, that's called flexion. But when she does the exact opposite thing and extends her arm out, that's extension, and that would be an increase of angle. And orthopedics, especially the subspecialty of orthopedics, which is sports medicine, they love goniometers. And a goniometer it's like this little thing, like a little protractor that measures this angle, so that you can document either improvement or degradation of your ROM, which is your range of motion. Adduction versus abduction. If you abduct somebody, okay, you're taking them away from something, aren't you? So if you're using midline, right, as your starting point, if I'm moving my leg away or my arm away from midline, that's called abduction. And if you have 2 things that almost sound identically alike, the exact opposite is adduction. Or I used to think of it like I'm adding my limbs to the midline. Either way, memorize one like your life depended on it, and your other one is simply the exact opposite. Rotation, also known as circumduction, that's easy. Go around. Pronation versus supination. This is how I always remember. PPD, pronation, palms down. Makes your life easy. So a pronation supination test is a test for not only for your muscles, it's also a neurologic. It's part of your mini mental stats exam in neurologic, which you get to learn later in future training. For you clinical people in the room, and for people who aren't clinical, you know, you should know what it is. Because if you read a report and said my patient is unable to pronate or supinate their right hand, then you know, okay, that's a movement problem. I'm either going to have to call orthopedics or I'm going to have to call neurology. Those of you who love your 4-inch heels, you guys know this, right? Eversion, inversion. Eversion when the sole accidentally goes outward, right? Inversion when your sole actually goes inside, right? And classic is, you know, you're walking up and downstairs, and you know, at the club, and you had maybe 1 Mai Tai too many, and don't have to be drunk, but you have to be a little bit impaired, or not even. I remember at pinning ceremony, we warned the nurse candidates, there are stairs on the stage, but you know, for the sake of beauty, everybody. That's why now we have actually, you'll see on graduation and also on the pinning ceremony, we have somebody at the stairs, you know, to hold your hand, and especially those of you who love your 4-inch heels. Dorsiflexion, plantar flexion. This is how, this is related to your Babinski planar, Babinski plantar, not planar, plantar reflex. You know, when the doctor in the emergency room or the nurse in the emergency room tickles your feet, you know, they run a pen or a light pen underneath your toes. I mean, underneath the sole of your feet. Well, plantar flexion, this is how I always remember it. Where do plants go? They go into the ground. So plantar flexion points to toes. It goes points to toes into the ground. And dorsiflexion is the exact opposite. That's that's essentially how me personally, I try to remember it. But whichever way you figure it out, just know that what? Memorize one like your life depended on it, and the other one is simply the exact opposite. And nice to know. This is highlighting your appendicular skeletal system, and that's your appendages or your arms and your legs, and they're colored in this grayish blue. And this is your axial skeletal, which is colored in you know, this desert sand tone color. So let's look at some bones. Oh, excuse me. Ooh. Why am I yawning? I had like a million hours sleep last night. Let's make this a little bit bigger. So your carpal bones, those are your wrist bones. And you could have carpotosis or a downward displacement or a drooped wrist due to maybe it could be a neurologic, maybe it's a tendon problem like carpal tunnel syndrome. It's a tendon problem that turns into a neurologic, that kind of thing. Cervical, we already saw in our neck of our vertebrae. It's also used in the uterus when we talk about obstetrics, because the uterus or the uterine muscle forms like a little bottleneck at the bottom, right as it connects to the vaginal canal, and that's also known as your cervix, or specifically cervix uteri. Costo means ribs. So your subcostal area is the space right underneath your ribs, which, by the way, don't poke somebody there because there's arteries, veins, and nerves, and that's why it's painful when you poke somebody in the chest, especially in the subcostal area. Your cranium, that's your skull. I could cut into it. Now, ICP is increased intracranial pressure. Your skull is not your skull, your brain is surrounded by water, and there's a specific pressure there. If it's too much, it starts squeezing on the brain, and anything that squeezes the brain kind of tends to shut off your breathing and your blood pressure and all that. So we got to perform this thing called a craniotomy. We don't really cut into your skull. We drill holes in it so that we can relieve the intracranial pressure or control breathing or bleeding or remove a tumor. But typically, a craniotomy is used for increased ICP and then to relieve that pressure, because that's bad news. Humerus is your upper arm, right? Or your brachial part of your arm. And that's your funny bone because it's humerus. Metacarpals. Now, let's look at, you got your carpals and then your wrists. Now, the dorsum of your hand is called metacarpals. Meta means change because it's changing from your carpals to your phalanges, which is your fingers. You also have the same thing with your ankle. Your ankle bones are called tarsals, but then it changes on the dorsum of your foot to metatarsals. And then, of course, your toes are your phalanges. Now, how can you tell phalanges in your fingers versus phalanges in your toes? The phalanges in your fingers are labeled upper extremity, and your toes are phalanges lower extremity. Sternum, which is your breastbone. So if you have sternal costal pathologies, it's not only affecting your breastbone, it's affecting your ribs, which is usually the case, especially for really malignant invasive ductal carcinoma of the breast. Loves to go to bone, and it spreads right into the sternum and right into the ribs, and then it goes into your lungs, and that becomes bad news. Vertebra, didn't forget you, that's your backbone, and you could have inflammation of this vertebrae, and that's called spondylitis. I don't know why they don't just call it vertebritis. Maybe it sounds weird, vertebritis, but that's spondylitis, okay? And an ankylosing form is one where it gets fused up and gets stiff. Hence the term ankylosing spondylitis. Calcaneum is your heel bone. Calcaneodynia, right? Again, pay attention to your feet and your knees and your ankles. Femur, largest bone in your body. It's your thigh bone. So your femoral artery has to be located. Ooh. Why am I yawning every 2 seconds? Femoral bone is your femur, which is the largest bone in your body, and that's your thigh bone. By the way, it takes a lot to break that. Like, you know, in the movies, you see, you know, John-Claude Van Damme, like, just kick you right there and think they'll snap. No. My last couple of patients who fractured their femoral or their thigh bone, their femoral bone, they got hit by something big. One was an MTA bus, and the other one was a FedEx van going around 35, 40 miles per hour. Which, by the way, did any of you see that psychopath, the one who ran over all those people? That's just when you think the world ain't crazy enough, someone always proves you wrong. Your fibula. Now, you also have your tibia. Now, your tibia and your fibula, the best way to remember it is this. Tibia is the bigger bone, and the fibula is the smaller bone in the back, right? I always go a fib. A fib is usually a small lie, isn't it? So smaller, back. And tib-fib fracture is when you hit this and the tibia is so big, it'll also fracture the fibula as well. But remember, tibia, that's the one in the anterior. Fibula, the little white lie in the back. That's the one in the back. But like I stated, whatever silly thing that you can get in your head for you to remember stuff, use it. Your patella is your kneecap. We could do a patelectomy, right? Sometimes we replace it, sometimes we don't, depending on what orthopedics wants or what the patient needs. Pelvis, pelvimetry. We can do that via ultrasound, but pelvimetry is performed digitally or with your hand in the Department of Obstetrics. And that's also part of the reason why they're putting their hands inside your vaginal canal, because I want to measure things. We have training in obstetrics for that. And residents and, you know, consultants in obstetrics, they're really good. They get it down. They can get it down to the ½ centimeter, and it'll be just as reliable. Pelvis, radiograph. That means an X-ray. So the radiographer is the technician. Radiologist, that's the MD, right? And radiography, that is the process of taking an X-ray. And of course, in the Department of Radiology. Ankylosing means bent or crooked, secondary to stiffness, and we already mentioned ankylosing spondylitis. Arthur is a joint space, so that's what arthritis is. It's an inflammation or an infection of the joint space. So no matter what you have, osteoarthritis, rheumatoid arthritis, gouty arthritis, the best person to go see is a rheumatologist, because that joint space of yours is inflamed. And if anyone ever had any family members who have gouty arthritis, ooh, that really hurts. It just, I don't know. To me, it feels like hot poker going through my either ankle, big toe. It usually affects the big toe, but for me, for whatever reason, it's my knees. Probably because of all the damage to my knees. But hey, who knows? But my rheumatologist. Costochondritis, inflammation or infection of the cartilage, chondro, in my ribs. And remember, your ribs can't be totally all bone. It has to have some flexibility so that you can breathe. Right now, put your hand on your chest. Take a couple of deep breaths. You feel that? You feel your chest move up and out? Well, If you had costochondritis, it would be painful to do that. Okay, it would be painful for your chest to move up and out. Laminectomy. Now your lamina is a part of your vertebral arch. Let's look at your vertebrae. So this arch thingy here is your lamina. This is a facet that connects into your, because this is your thoracic vertebrae. And this is called the pedicle, this little arch here. So this big arch here, lamina, this little arch here is your pedicle. Now, this is your intervertebral disc, and this is your spinal nerve coming out from here, which is your spinal cord. You could see that if there's a misalignment of this or this, it's going to start impinging and start pinching the spinal nerve. If you start pinching on the spinal nerve, you're either going to have pain, paralysis, or both. You're going to have problems. So we can do a laminectomy, cut this out, and that will alleviate the pain. Okay. Oh, here's another pretty picture. See, you can cut this part out. Pedicle. Transverse process, of course, is going what? Across. And this is your intervertebral disc. Well, no, not this, but this is the body of your vertebrae. But in between is a piece of cartilage. Let me get that bigger. In between is a piece of cartilage, and that's your intervertebral disc. Inter meaning in between. Osteo means bone, of course, and a bone is a living, breathing thing. It can get inflamed. It can get cancer. So you can have an osteosarcoma. You can have an osteocarcinoma, and you can also have osteitis. Orthopedics we already mentioned. Myelo, that's bone marrow. I just mentioned that bone is a living, breathing thing, and they have red marrow and yellow marrow inside this, inside your bones. So if you have myelitis, you have inflammation or infection of that said bone marrow. Or if you have a myelocele, you have a herniation or abnormal swelling of your spinal cord. Either way, not a good thing. Osteocyte, mature bone cell. Let's do the bone cells. So you have mature bone cell, osteocyte. Then you have the immature bone cell, that's osteoblast. And then you have the bone that, the cell that breaks down bones is osteoclast. So osteocyte, mature cell. Osteoblast, immature bone cell. Osteoclast, think clash, think something breaking or breaking down. An osteoclast is a cell that breaks down bone, because inside bone there's magnesium, calcium in it, and we sometimes have to break it down, not only for restructuring and remodeling, we also use it to release calcium when we are hypocalcemic. Where am I? You could also have osteodesis or arthrodesis, is a fixation of a bone or joint. The way we do it through pins and metal plates. Yes, the same tools that you can get in Home Depot, the Department of Orthopedics uses. They just sterilize it and they put it in, they wrap it around in plastic and stuff when we're doing surgeries. And it's hardcore. Like they got hammers and chisels and stuff. It's really neat. Osteomyelitis, or Malaysia, potato. Secondary to vitamin D deficiency. And if you have no vitamin D, you have no way to process your calcium. Therefore, your bones will start softening. And then you'll get a pathologic fracture. And then that'll be that. Your diaphysis. Best way to look at this is look at your long bone. If you look at this long bone here, you could see the ends epi on top of is called your epiphysis. But the shaft of the long bone, and this is a femur that we're looking at, is called your diaphysis. Dia means complete or thorough. Then in between, you'll have the metaphysis. Meta means change. And you look on the ends of the long bone, they have articular cartilage. Cartilage is much softer than bone, but it's made out of the same stuff, and it's just this, it's kind of tough as well. And its function, now I'm going into anatomy, which I shouldn't. But the function of your cartilage on the end of your bones is to decrease friction and decrease wear and tear on the ends of your bones, also known as your epiphysis. Osteoporosis, that's easy. It's when the osteoclasts get a little bit out of hand. When you get older, your body likes breaking down things versus building them back up. So the osteoclasts and poor diet can lead to osteoporosis. That's why, especially in female patients greater than who've had children greater than age of 45, because their bones are used to breaking down so they can make calcium for baby. It's the pros and cons of being a mother, which I know nothing about. Oh, here's another. And you can see bone is a living, breathing thing. It's hollow. It's got things in it. It has arteries and veins in it. There's fat in there. There's blood in there. Actually, you have goes hematopoiesis and hematogenesis going on in the bone. Osteogenesis is the formation of bone. Hematopoiesis is the formation of blood cells. There you go. Erythropoiesis, leukopoiesis, if we want to be specific, and that happens in bone. So if I have a bone problem, you're going to definitely have a blood problem as well. Or if you had a blood problem like leukemia, you're also going to have a bone problem. I always talk about this story. I had I don't know, she was 9, 10 years old, and she was playing soccer in the park. It was in Central Park, and it was the middle of, I don't know, I could say September, October. And she was just wearing normal sneakers, and it wasn't really cold outside. It was maybe 50, 55 degrees or so. That's what I recall. And then I was working ER in St. Vincent's. And she came in with 2 fractured toes. I thought that was odd. Well, we did the blood work, and we found what? There's indications of some sort of anemia. We looked even further, and then we gave it to the hematologist. They confirmed, and also pathology confirmed, that that little girl had leukemia, and that the fractures of her toes were due to pathologic fractures. The bone was weakened due to the cancer, which now started in the blood and now ended up in her bones. That was rough, because I remember the mom just being irritated, like, why are we taking so long to set 2, little bones? And I remember how it was rough. It's the rough part of our job. Telling people horrible stuff. Calcemia, emia, blood condition, calcium. So hypercalcemia, not a good thing. Too much calcium in my blood. Hypocalcemia, too little calcium in my blood. Either way is not good. Everything should be in the middle. My patient should be normal calcemic, also known as eucalcemic. Radiology, no one calls it Roentgenology anymore. I don't know where that came from. Roentgens are the measurement of X-ray radiation. Which, by the way, little side note, you guys work, those of you who work clinically, don't go down there unless you really, really have to. Do not be in the room unless you really, really have to. And if you are in the room, wear that big, long lead bib that they make you wear, and stand behind the shield, because you get exposed enough. Remember, X-rays killed Marie Curie. Genesis, we already went over. Osteomyelitis, okay, that is inflammation or infection of my bone and spinal cord. and Staphylococcus. And it's through what? Right now, on all of your skin, you have tons of Staph aureus or Staphylococci aureus. All you have to do is break the skin, which either in trauma or surgery happens all the time, right? And then staph infection gets bad. Once it gets bad, it can go to your bone, it can go to your spine. See, like right here. Oh, diarthrosis, amphiarthrosis, and synarthrosis. Now, diarthrosis, dia means complete or thorough, thoroughly or completely movable. Amphiarthrosis means what? Somewhere in the middle. Synarthrosis, syn means the same. So if two things are the same, that means they're standing still. So that's synarthrosis. So diarthrotic, amphiarthrotic, synarthrotic, and the person who's really great at that is, of course, the Department of Rheumatology. I've had this done to me. Right? This is a arthroscopy. Arthur, joint space, scope. And you can see how it's much better than, you only have to drill like 2 or 3 holes to do little mini surgeries and stuff like that. Versus back in the day, I had to cut this whole thing open, move this patella out of the way. It's just nasty. Nowadays, just 3 holes. One for a surgical instrument, but nowadays the viewing scope and the surgical instrument are one and the same. And an irrigation instrument, they usually pump saline to puff all this up and so that it opens everything up. You see the cartilage damage here. Here's your hips. Here's a radiogram of your hips. And this is a one of those ways that we can stabilize a joint space using tools and metals, pins and plates. I think we went over all these. Oh, now cephalo means head, but encephalo means brain. So I remember in week 2 notes, EKG versus EEG, an electroencephalogram. That is a machine that measures the electricity in your brain. Encephalitis, inflammation of brain tissue, usually highly contagious. So again, you don't have any business in that room, don't be in that room. Softening of the brain and encephalomalacia. Okay. AIDS, HIV, encephalitis, caused by herpes. And that's why back in the day, when people didn't get treated, they went insane because their brain got inflamed or infection. People who had, that was before, the era of antivirals. Herpes is just one of those, it's the gift that keeps on giving. Once you have it, it's really, really intractable. It'll always come back. Here's some examples of fractures. Nice to know. Don't have to know. Transverse. This is a closed versus open, and this is an oblique fracture. This is green stick, where it's partial break on one side, and then the other side, just bends. This happens usually in children less than 5 years of age. This is comminuted fracture, where it has all these little bits and pieces. Most common is GSLW or gunshot wound. Remember, it's not the bullet that you should be worried about. You should be worried about the massive amount of energy the bullet takes with it. And let's say, for example, the bullet just grazed this person's tibia. Well, the force, the shock wave of that bullet will shatter all of this. That's 5. that impacted? I guess it could be impacted. This is a Colles fracture of your wrist. I don't know what this is. Well, fracture of your ribs. And this might be a compression fracture. Compression fractures are usually found in the spine, and it's usually what do you call that? When people want to jump from a height, and then when they hit it, and it compresses all their knees and their hips and their spinal cord. That's why I always say, if you're going to try to kill yourself, really, really, really try. Because when I was in EMS, how many people jump from only like the second or third or fourth story and they live? I'm not saying to go kill yourself, but man, there are far greater things worse than whatever situation you're in. Things could always be worse. That's actually how I live my life, through positive pessimism, so that I don't get really super depressed, because I cherish what I have, because things could always be much worse. Here in the United States, I find that it's almost a sport complaining. But you know, I was with the World Health Organization for 2 years and traveled all over the Southeast Asian basin, and I've seen what true poverty looks like. And it isn't it here, not by a long shot. That's why I always cherish what I got, because there's a whole bunch of people in this world who have far less. Here is your vertebrae. There are 7 of them in your cervical, 12 of them your thoracic. I believe 6 of them. 1, 2, 3, 4, 5. 5. 1, 2, 3, 4, 5. I can't remember. 5 or 6 lumbar, and then you have these fused bones here, and that's your sacrum. And the last one is your coccyx, or your tailbone. Okay. And these are the natural curvatures of the spine. Oh yeah, I forgot. The way we label all of these, we label them by numbers. So this one would be C1, C2, C3, C4, 5, 6, 7, T1 through 12, L1 through L5, and then your sacral is just, of course, one big thing. And that's how we number nerves, your spinal nerves. That's also how we number the vertebrae or the bones. Okay, where am I? Oh, we're at abbreviations. AIDS you always need to know. Now, AP and PA. Let's see. Now, what's AP? He goes, what's an AP film versus PA film? Right? There you go. Here's a PA film, or a posterior or postero anterior film. Posterior means back, anterior means front. So the X-ray is shooting X-rays at you from the back to the front, and that's called a PA view. Okay. Now, an AP view is the exact opposite, right? It would shoot from the front to the back and then to the plate. What is this? Is there another one? No. And then it'll give you different views, different viewpoints, and then you could see, like here, these are called curly A's, curly A, curly B lines. So you could see different types of information in different places, and just know that if they order a PA film, it's very different from an AP film. That's AP And didn't have PA here, but that's the exact opposite. I already talked about this, how we label vertebrae by numbers. DO is a doctor of osteopathy. Now, maybe back in the day, like 1940s, 1930s, they'd be a different species of doctor. But nowadays, a DO has almost identical responsibilities and training as an MD. Even in the past, during my time, a DO couldn't do minor surgery, but nowadays they have extra training and they can. CT scan is a computerized tomography scan. It takes multiple. Oh, you think a typical radiograph has a lot of radiation? CT has tons, anywhere from 32 to 64 slices or views. That could be potentially 32 to 64 times more radiation. So like I stated, if you don't have to be in that room, don't be in that room. Me personally, I'm almost never in the radiology room. I give the order and then I go get the wet read from the radiologist. I don't like being down there. Carpal tunnel syndrome, no one calls it CTS. I don't know where that's come from. Fracture, yes, it's capital F with a little X. HNP, herniated nucleus pulposus, also known as a herniated disc. I never really heard that before, but we always say the term herniated disc, or when the intervertebral disc. Let's look at that. If you're looking at this, this is the nucleus pulposus of your intervertebral disc. All of this here is cartilage. So it's like bone, but softer. It provides a shock absorber in between the bodies of your vertebrae. Well, what happens if you have a herniated nucleus pulposus or herniated disc? You could see that it starts to impinge on the spinal nerve right here. And here's another view of it, and that's a problem. It's going to cause significant amounts of pain and paralysis. So that's not a good thing. MG, myasthenia gravis, and never really called that. RA, rheumatoid arthritis, yep, they call it RA. THR, never really called it total hip replacement. But RA, AP, PA, CT, DO, those are common. Okay, we're not going to go over the pathology. Oh, there's the herniated disc picture. You can see here the nucleus pulposus impinging on a spinal nerve, and you can see how one of the management is to perform a laminectomy. I take this part of the bone out, and then this will be nice and free, right? So it won't cause pain or paralysis. Yeah, this is my future. Nodules. I have just swelling now, but when I get older, I'm gonna have this, and they're very painful. Here's the different curvatures of your spine. Now, normally your spine should curve only upon lateral view. Upon PA or AP view, it should be straight. Scoliosis is when there's an abnormal curvature of the spine, like so. Kyphosis is what they call humpback. Lordosis is called swayback. Ooh, another really what is it called? Abbreviation, really important abbreviation is NSAIDs, are non-steroidal anti-inflammatory drugs. Okay, they're for mild to moderate pain, mild to moderate inflammation. Okay, stuff like Tylenol, naproxen, ibuprofen, they're pretty good, and they're not that dangerous. Let's see. Let's jump right to let's jump right to the cases. So if you're looking at the case like this, case of Arthur Rexon, let's say, I don't know, it looks like 29-year-old male, seen today by Dr. Meyerson, and it's a radiology report. So who is Dr. Meyerson? He's a radiologist. Okay, so could there be more than one Myerson in the whole hospital? Of course. So when I'm calling for a radiology report, I have to say name, number, date. Yeah, Dr. Myerson signed off on it, Department of Radiology. Okay. AP and lat views. So how many views did he have? Two. He had a lateral view from the side and another view from the front to the back. AP view showed displacement of his L5 on his S1, meaning his last lumbar is now impinging and pressing on his first sacral sacral bone. The L5-S1 intervertebral disc has a slight shadow of decreased density. That means what? It's breaking down for some reason. There's narrowing of the L3, L4, and L4, L5, meaning the spacing between them, which was normal, is starting to get thinner. And that's not good. It's showing compression of his spine. They performed bilateral laminectomy. Bilateral means bi means two. So the laminectomy on his level of L5-S1 was removed on both the left and the right side. Now, just looking at those first couple of questions, there's tons of questions I could ask. I could ask, how many views did we have? What level of the spine was the view? Who did the report? Dr. Myerson. What department is he in? Radiology. It goes, was L5-S1 intervertebral disc the only one that had a problem? No. L3, L4, and L4, L5 was also a problem. Then what happened? It prompted a bilateral laminectomy done at the level of L5-S1. So you could see almost every, even though this is a small case, almost every sentence. And impression is the same thing as the diagnosis. So what is the diagnosis of Dr. Myerson? Well, looks like he has degenerative joint disease, intervertebral disc L5-S1. He has slight narrowing of L3, L4, L4, L5. That means I got to start looking at this. And slight motion goes on all lumbar and lumbosacral levels, which is semi-normal. But the very fact accompanied by this stuff, it's cause for some concern. And you could see some of the words. What does hypertrophic lip mean? Right? Does it mean it was growing or it was shrinking? Hyper, too much. Troph, growth. Let's look at the next one. Patient is Mr. Zhang. Dr. Anderson did an operative report. That means Dr. Anderson was the surgeon. What kind of surgeon? Well, he had a rotator cuff tear, right shoulder, degenerative arthritis, right acromioclavicular joint. That means the joint that connects his scapula and his collarbone is starting to wear away. Hence the term degenerative. Okay, and Dr. Anderson is the orthopedist that did the surgery. What kind of anesthesia did we give him? Xylocaine, 1%, only local. And I also did IV sedation, which is weird. I did both, but potato, potato. I'm thinking, what else could be? Well, I could ask you anything specifically. It goes, what did we perform on his glenohumeral joint? Did we A, remove the joint, B, right, scope the joint, C, suture the joint, D, put a plate on his glenohumeral joint? No, if I gave you this line, you only scoped him. You didn't do anything else. Right? Let's see. Did we do anything? No. So when we're looking at this, oh, by the way, AC joint is the acromioclavicular joint. Okay. But you can see here how you could easily crank up 5 questions that directly relate. And don't make it so easy like, what anesthesia did you use? Of course you use xylocaine, right? How about this kind of question? And it goes, what is the function of xylocaine 1%? Is it one, to put my patient to sleep? Two, is it to so that I don't feel anything? Three, is it to remove his AC joint? Four, is it to spend more money? Now, you look at the word anesthesia, ia, state or condition, and, no or not, aesthesi, feeling. So the xylocaine 1% was used as anesthesia only locally, but we had to use an IV sedation. So we probably used benzodiazepine. Benzos, love them. Okay, so that's a good question, and that's the kind of question you gotta a little bit, expand a little bit. So here's another question for degenerative arthritis: is his shoulder going to get better if we don't do anything about it? If we just let him heal up? Nope. It's degenerative joint disease. So what's going to happen? It's going to get worse and worse and worse until I got to do something. Is that the only arthritis he has? Nope. He also has gout. Ugh, poor guy. So many problems. Now, with that being said, I think we're at the end of this chapter. This is a good thing. So review what's due next week. Medical language lab, critical listening exercises 1, 2, and 3. Response exercises 1 and 2. Do not do practice unless you want to have some extra practice. Do your quiz, and of course, create a quiz using those 2 cases, and you should be good for next week. It's at this portion of the show that I stop recording.